morning, ladies and gentlemen. Welcome. It's a pleasure to have you here. I am Lilia Villar, and I am part of the medical CITMER team. It's a great pleasure to have you here to present the great work done by international physicians and by my medical director and my director general of the clinic. It's a pleasure to tell you about this work. It is to break a paradigm over what we used to know about the ovarian function and the process of ovulation. So what we will be presenting is something relatively new. The description of us like humans having ovulation was described in the 80s, and no changes had taken place. But this can actually change our management we use as physicians. The intention of all the professionals involved in this is to do simpler, more comfortable, and cheaper treatments for patients without this compromising the results. We always try to tailor-made and to have the best result. This is a great tool that Dr. Lina, Dr. Israel, and other doctors developed. I thank the press for being here and for you to know the information we will present. Online, we have Dr. Michael Allen from the Advanced Fertility Center of Texas, Dr. Beata Tralik from the Assisted Reproduction Center in Texas, and Dr. Michael Diamond from the Augusta University, Dr. Dimitri Dosortev, which is it's a pleasure to have him here. He's our scientific director, and also from the Advanced Fertility Center of Texas. It's a great pleasure to have you here. And now we are going to tell you about this paper recently published on February 20th, 2023 in a high-impact journal for us doctors involved in assisted reproduction. This journal assesses assisted reproduction matters and genetics. So it's a pleasure to introduce Dr. Lina Villar. Dr. Lina Villar, aside from being a great woman, a great mother, she's also a great scientist. You know that nowadays it is more difficult to have women involved in science. She has 6 publications, and she has always been interested in ovulation since she was a resident. She will make a presentation. Aside from the fact that we all face infertility, probably we know people knowing this, and the objective is to improve treatments and prognosis of our patients. Very well. Hi. Thank you for being with us. It's an honor to be with you to discuss our new publication. With the collaboration of Dr. Dimitri and all the doctors from the Advanced Fertility Center of Texas, and with Repronoa also, we are discussing this new scientific knowledge that will break paradigms and will improve assisted reproduction techniques in our country. Let's proceed to our presentation. We did. Entonces les voy a I will discuss our scientific paper, which is pregnancy and live birth after the triggering with progesterone. This is very new and that will break paradigms, as Dr. Lilia mentioned. In the past, we used to believe that estradiol was a hormone that produces a follicle in development, and that estradiol caused the LH surge that will make the follicle to break and causing ovulation. But here we discuss that this is not the case. But before this, let me thank you for being here. I thank all the people online. And this is a preamble of the way in which a natural pregnancy occurs. There's the menstrual period in the woman, and in the ovary, there's structures called follicles that begin growing, that have the egg cells, and then they begin to mature at the size of 2 millimeters, and then spontaneously it is broken, and the egg cell that will be fertilized is released, that will later implant in the endometrium. This follicle, this follicle where the egg cell is released has cells of the granulosa. They will produce the corpus luteum, producing the necessary progesterone for implantation and for implantation in the endometrium. But also the corpus luteum will produce other important substances for the right presentation of the embryo, like relaxin. But treatments of assisted reproduction is not a natural one. Sometimes we require certain processes to achieve pregnancy with different steps involved. First, ovarian stimulation. We make many follicles grow to obtain mature egg cells to fertilize them, producing embryos to be implanted in the womb of the woman. But many of these embryos need to first be frozen, and then embryos have to be transferred in a substitute treatment. And most clinics of fertility, the treatments are done with substitute drugs so that the endometrium can hold the embryo. These treatments entail time and many drugs that are necessary for the embryo to be implanted. Sometimes birth control pills are necessary to inhibit the formation of mature follicles. Then agonists are given for the hormones necessary to inhibit the hormones produced by the ovary. And then estrogens are given for several days, a minimum of 2 weeks. And then after this time, for a period of 3 months, injections of progesterone between 50 to 100 milligrams are added, or body progesterone or vaginal progesterones at high doses, morning, afternoon, and evening, very uncomfortable for the patient, that something that can cause pain, and it's also costful. And they cannot have a normal day because they have to be applying the progesterone at different times during the day. So it's not comfortable at all. It generates stress. And also, this is a totally artificial treatment. It does not generate a corpus luteum that will be normal in the process of ovulation, because, as I said, the corpus luteum produces progesterone. We are adding progesterone, but there are other substances produced by the corpus luteum to be able to present the embryo. This progesterone, if it's not the right one, if it's not properly given, can cause low levels of progesterone that can cause a miscarriage, spontaneous abortion. And it can also be painful, uncomfortable, and very, very costly, because this means 3 months that can be very costly for the patients, and sometimes just cannot afford it. But in 2020, Dr. Seth, Dr. Diamond, and Dr. Pellicer discovered that the physiological trigger of ovulation is progesterone. So this breaks paradigms in all treatments of assisted reproduction. This is like a watershed that can change assisted reproduction at the world level. That is why we are holding this press conference, for you to know that these doctors, in association with our company, have been able to achieve the first case with natural trigger of progesterone and a live birth. In 2020, they first reported that all the review they conducted where they informed that progesterone is a trigger of the luteinizing hormone that causes ovulation and not estradiol, because we all thought that at certain levels of estradiol, surges of LH could be caused. This is a paradigm that we all physicians in assisted reproduction had. So, in the protocol, a protocol was conducted to be given to the patients. It's a natural one. We are evaluating women in the development of their dominant follicle with the menstrual period. A follicle begins to grow, and it has the egg cell that is maturing. We see a follicle that reaches 17 millimeters. We can add an anti-inflammatory to avoid a premature rupture of the follicle so that it is bigger. The bigger the follicle at a size of 22 millimeters, there will be more cells from the granulosa. In generating ovulation, it will produce a more competent corpus luteum, firmer, that will allow pregnancy to withhold. When it reaches a size of 20 to 22 millimeters, a progesterone injection is added, but at a very low dose, not compared to what is needed in an artificial treatment. The vials in Mexico are 50 milligram dose, and it's just 1/5 that is given to the woman. And then 24 hours later, we assess with blood tests that ovulation was induced, that the LH surge occurred, and we assess this with ultrasound that will produce a competent corpus luteum so that the pregnancy can take place in the first 3 months, because after the 3 months, progesterone will produce the placenta. This is a treatment requiring one single injection, totally natural. No more drugs are needed because the body produces it. It's simple and very economical, very cheap. And the case of our patient, she's a 37-year-old patient with 2 years of infertility, looking for pregnancy. And then later, the IVF with embryo transfer was done, but it was a failure. She couldn't get pregnant. She had cryopreserved the vitrified embryo, so we didn't need more embryos. We could work with them, but a special treatment is needed to receive the embryos at the right time. It cannot be done at any time. There's a window of implantation, which is the ideal time for the embryo and the endometrium to make a connection. And she still had 2 frozen embryos with good quality. We analyzed the remaining embryos were low quality. She didn't want to get high doses of progesterone vaginally. It was costly for her, uncomfortable for her. She wanted something more natural that could give her the same probability or even more to reduce all factors that could make her feel bad. So we discussed this, and she accepted undergoing this treatment. We had to do follicle follow-up more often with the examination to know when the follicle reached the right size. 17, 18 millimeters diclofenac was added to avoid the rupture of the follicle prematurely. When the follicle reached a 20 millimeter size, we administered the progesterone injection IM with 10 milligrams, 100 milligrams, and then progesterone 10 milligrams, and the embryos were transferred 7 days after the IM progesterone was given, with the transfer of two embryos. And after the embryo transfer, 10 days later, we received a positive pregnancy test. She was very happy. She did not require any supplemental treatment. We had to do a more strict follow-up, but the result was positive. We did follow-up of the babies to see that we had the right fetal development and fetal heart rate, heartbeat, and then the presence of the two babies. We documented this event because this is something new, totally different. We are opening the possibility of having more natural treatments in patients requiring a treatment of assisted reproduction technique. And this was a twin pregnancy. And this is the birth of these two babies. This is the first one documented with this technique, with the trigger of natural progesterone. Totally natural, as I said. Very comfortable. One single injection to induce the LH surge. There's no need for luteal phase support. Much better than having to have a supplemental treatment to do what is necessary with the luteum, corpus luteum. It also reduces risks because there's no natural ovulation. The known risks with treatments of estrogen, synthetic estrogen are hypertensive disease in the pregnancy. There's an increase in preeclampsia risk with these treatments because the corpus luteum not only secretes progesterone but also relaxin. A bad presentation could induce gestational hypertension. And also, this will all improve the health of the baby and of the mother as well. This is our publication that we wanted to present. It's very important in assisted reproduction. Assisted reproduction. Thank you, Dr. Lina. Very valuable information. We thank also Dr. Dimitri for the support in this investigation. I will give the floor to Dr. Marie Turner in order to share this information with the doctors that helped us in the development of this paper, this article.
Dr. Marie Turner, can you help us?
Sure. Can you all hear me? I'm sorry. I think I was muted.
And we can hear you.
Can everyone hear me? Okay, perfect.
Yeah.
So first of all, I guess I just wanted to make a point of the uniqueness of this medical breakthrough, really, and the fact that you started with a simple hypothesis that progesterone could be the possible trigger for ovulation.
Speak a little bit louder, please.
Sure. Can you turn me up?
No, I think you can turn. Oh no, we can hear you. We can hear you. Continue.
Okay. But that we've taken that hypothesis and within 2 years discovered that progesterone is the physiological trigger for ovulation, and incorporate that into clinical practice is truly incredible. Something we've been doing for 75 years to change in a matter of 2 years is really an amazing thing. So I'm going to go ahead and start with a few questions for Dr. Villar. The first one, how did you go about choosing this first patient to trigger with progesterone?
Well, we chose this patient because she had a previous failed cycle with good quality embryos and no pregnancy occurred. We wanted something that could differentiate the previous treatment, something that could improve the production of a right implantation. She wanted to have something more natural also. So since we knew this triggering with the progesterone that can cause a better corpus luteum and the right serum progesterone, we discussed this with her. She was a young patient with good embryo. She couldn't get pregnancy. The prognosis was going to be bad if we did the same thing. So we decided to change the strategy to improve the conditions and the prognosis of.
Okay. So then based on that, is there anything that you would change with your next patient in triggering them?
Sí, bueno, algo que pude observar.
Something I was able to observe that at the beginning it can cause uncertainty when it comes to new treatments. Something new. So in this patient, when I saw a 20 millimeter follicle, I did the trigger with progesterone. And with this, we saw that serum progesterone after some days was not so high. So we were afraid of not having the right progesterone. If we had left this longer for the follicle to grow to be more competent, 22 to 24 millimeters, 1 or 2 days more for the follicle to develop so that the corpus luteum would be more sustainable. But well, things went very well. Doing that with a smaller follicle probably wouldn't have given the desired result.
Okay. So because people are going to ask, is the progesterone that you're using a natural product?
Yes. It was natural progesterone. Oily or in oil. Oil progesterone. And only 1/5 of the progesterone was administered because it comes in 50 milligrams, but only 1/5 was given. Totally natural progesterone. No synthetic progesterone was used.
Okay. Thank you so much. I'm going to move over to Dr. Michael Alon, who is president of the Advanced Fertility Center of Texas. Dr. Alon, are there any other methods that you are currently working on to improve implantation of embryos in addition to triggering with progesterone?
He's muted. I think he's muted.
Oh, okay.
Yeah.
Can you hear me?
Could you hear me?
Okay? Yeah, I can hear you.
Okay.
Can you hear me okay?
We can hear you.
Yes.
So basically what we did is we're trying to create a model that allow you to study the interaction between the embryo and the endometrium. And so the model basically contained where we took a biopsy of the lining of the uterus, and then we place it on a collagen, like a hydrogel. So now you can create like a 3D model where you could put the collagen matrix and put the endometrium on the top. And then you could test the interaction between the embryo and the endometrium that you created. And the model basically allow you to test embryo implantation. Hopefully what we're really trying to get out of this in the future, that we'll be able to personalize the implantation of the embryo before the process. So probably we'll take a sample of the lining of the endometrium, apply the model to the patient, and then give her some prognosis whether her uterus is more likely to be receptive for embryo implantation or not. And if there are possibly ways that we will be able to correct it in the future.
Incredible. That's amazing. Okay. Over to Dr. Tralik, who is also with Dr. Alon at Advanced Fertility Center of Texas. Dr. Tralik, was it difficult for you to accept progesterone as a possible physiological trigger for ovulation?
Absolutely not. If you work with Dr. Alon and Dr. Dozortsev, nothing is difficult to accept. So first of all, I have been always very passionate about science, trying new things, progression to make myself and our clinic better. So when Dr. Dozortsev came to me with this idea, he explained the whole rationale behind the whole theory. Everything made perfect sense to me, and I was more than happy to jump into this deep water with him to check if it really works. And it did. So no, I had no doubts even for 1 second to try it out.
That's great. Yeah, it's an exciting place to work. Okay. Dr. Michael Diamond, who, how significant is this birth in the context of human assisted reproduction?
Well, as was shared during the presentation, a couple of years ago, this thought about the role of progesterone in being responsible for triggering ovulation and then for impacting the quality of corpus luteum function and luteal phase support was a hypothesis that we had and published. It is very exciting to have the case report here that has suggested in principle that yes, this hypothesis that we had is in fact correct. And we'll be very excited to see with larger trials more information about this, but this could have significant impact on both understanding of physiology of the human menstrual cycle and basic textbook teachings, not only to obstetrician and gynecologists and reproductive endocrinologists, but to individuals in graduate schools or even in high school. And further, if this hypothesis, which the case report suggests is correct, if this continues to be supported as further evaluations are done, it'll dramatically impact the practice of clinical reproductive medicine as we try to help couples who are having difficulty conceiving, helping them to be able to accomplish this in a different way, and hopefully one that will be less invasive and less time consuming and less expensive. So I think it could have a dramatic impact on both physiology as well as on clinical practice of medicine.
Right, agreed. Great. Okay, now to Dr. Dozorcev. Do you feel that your theory that progesterone is the trigger of ovulation has been fully validated with this case? And, is there anything that you would do based on this protocol that would improve or change anything?
Well, in medicine, in science in general, and medicine in particular, it's very difficult to have a final word. There is always room for doubts, but I think as much as it can be proven in medicine, I think it is proven that progesterone is a trigger of physiological trigger of ovulation. I also would like to say a couple of words about the first case report in the article, because the presentation was obviously about birth following triggering. However, this birth wouldn't be possible without first case report, even though it failed to deliver an outcome as a child. But this work, which was done by Dr. Chalik and Dr. Alon, laid the ground for the success which came in this second case when twins were born. It's very common that the first time it doesn't work, but it answers the important questions which enable success when you try again. And I think the credit has to be absolutely given even to the failed case, which that's why it was also in publication which we're discussing today.
Right. Agreed. Okay, is Mr. Maldonado with us?
Yep, I'm here.
Perfect. I couldn't see you. So is there anything different from an embryology standpoint for this patient? Did you expect these embryos to implant?
Sí y no.
The
Yes and no. The embryonal development that patients had at the beginning in the first attempt was a regular embryonal development. They did not implant. The second attempt,
Tuvieron 10 óvulos,
10 egg cells were obtained, and 4 oocytes were implanted, 6 were matured. So they had the same embryonal development as the previous one, and the embryos were also developed with a low quality from what we expect to consider high quality of these egg cells. So at the time when we saw this embryonal development, transferring 2 embryos, we thought that at least one would implant, but surprisingly enough, both were implanted and both were born. So the embryonal morphology sometimes does not indicate the genetic quality of the embryos, and these babies that were born through assisted reproduction with this treatment after the embryo transfer, after being thawed, because they were cryopreserved, was possible to do, and that made us very happy, all of us.
Excellent. Okay.
If I can add something,
Sure.
I would like to say that this work would not be possible without certain very unique qualities in physicians who participated in this work. Not only they had to be top-notch experts in the field, they also had to be brave enough and skillful and patient and open-minded to be able to accomplish this incredible work. And in my opinion, and I work with a lot of physicians, this is a very rare combination of qualities. So it's not just research, it's also this clinical abilities which make this discovery possible and actionable.
Absolutely. I agree. Absolutely.
Thank you.
Agradecemos enormemente a los doctores por su atención y
The doctors for their collaboration and the great support for science, always for the benefit of our patients who are our main engine. Thank you, Dr. Allen, Dr. Treilich, Dr. Diamond, and Dr. Dosortev for your participation with us, for this great contribution to science. For sure, this will be a change in medical management in the future. And now we are going to begin with our question and answer period. And let's do that in order, speaking one person at a time.
¿Podría por favor decirme su
Please state your name and where you come from. Araceli Candy or Checate Supplement from El Universal newspaper. My question is the following. With assisted reproduction, how many cases are successful in general, and comparing to this procedure? Do you estimate that the success will be better, will be higher? And is this already available in Mexico? As of when, for the couples, what are the kind of problems that couples can have to have access to this treatment? Well, treatments of assisted reproduction have a variable probability. It depends on several factors. The likelihood of pregnancy in the first attempt, like with our patient who was not successful in the first attempt, 65 to 80% of achieving pregnancy in the first attempt. This treatment, the one we are speaking about, are treatments for the transfer of thawed embryos. The idea of these treatments is to do this more individualized.
es mejorar el pronóstico de la paciente?
It is to improve the prognosis of the patient, to individualize the treatment, to reduce costs and patients being uncomfortable, to have a more natural corpus luteum that can reduce risks or complication in pregnancy as gestational hypertension that can be associated to these treatments of assisted reproduction. This is already available at CITMER. Dr. Dmitrieva, we've worked together very often generating science, and we're opening the doors of these possibilities for assisted reproduction. With these treatments, can we improve the probability of pregnancy? Yes, but these should be patients with regular cycles to examine them more often. That's why it is important to give them the different options, because all of them can be effective, but one could be better for the patient. Yes, of course, we have this treatment at CITMER. Any other questions? Luis Luna, El Sol de México, newspaper. Are the costs lower with this treatment, or they are increased if compared to the natural processes? And what would be the percentage? Well, the purpose of this new way of inducing ovulation to produce progesterone by the corpus luteum with in vitro treatments make these treatments cheapest. The economic costs are important because generally, of course, this depends on the country and the guidelines prevailing there, but 400 to 800 up to 900 milligrams of progesterone has to be applied every day. In capsule terms, it could be 4 to 9 tablets, depending on the brand. So if you do the calculation, patients would have to spend only for progesterone approximately 1,200 every day. I guess it's pesos. So if you only use 1/10 of the ampules and it costs less than 400 pesos, you are greatly reducing the costs for the patients. But not only that, you are also investing in the future health of the baby, unless it is a premature baby that involves disability for the baby, and you also reduce something, the cardiovascular risks for the baby in the future. If there's growth restriction in uterus, or if the mother has preeclampsia during the pregnancy, these babies are at a higher risk of cardiovascular problems in the future. So betting on more harmonious or solutions that are similar to what is physiological, you are also improving the health of the baby and of the mother. That is priceless in any country. That's precisely the intervention we want to have. Something better for the patients, not interfering with their lifestyle, and to have this as an investment for the baby's health. Before we continue, I would like to ask the doctors in the United States if you would like to answer some of the questions that the press has asked. If you would like to take the floor to make any comments about the previous questions.
Maybe I would like to add something. It's not only the cost is very important for patients, but also convenience. So instead of doing progesterone shots for 3 months, patients just triggered once for ovulation, and the convenience, it's extremely important. Our patients suffer a lot doing the IM intramuscular shots for 3 months. So this is also huge benefit. This is how I see it. Not only cost is important, but also convenience for patient.
Yes, doing more natural treatments with these options of a transfer of frozen embryos will help the patients to have a better life, and they will spend less in drugs. But as Dr. Lilia said, it's not only the cost that is entailed in a 2 or 3 month treatment, but also having a healthy pregnancy and a term delivery is important if your corpus luteum, if the formation of this corpus luteum just does the right implantation, reducing diseases still unknown in infertility, it can increase the risk of gestational hypertension so that more premature babies can be born and everything that is entailed by the birth of a premature baby. Anyone else from our faculty from the U.S. would like to answer a question or to give further comments? Treatments, assisted reproductive systems. This one in particular. Is it possible for any condition of the woman like us? I know that women with cancer can have access to assisted reproductive techniques. Would this treatment also be an option for these patients? Well, some. All treatments are personalized. You have to assess the kind of cancer, and we need to discuss this with her oncologist to see if the woman can become pregnant. But since this is a natural treatment, you are not giving hormones that could increase the cancer risk. But it is important, not all patients with some kind of tumor can get pregnant because gestation has an important hormonal burden. The pregnancy could also cause an important load because of the placenta. So you have to individualize every case. Anyone else? From our faculty in the U.S., if you would like to make a comment, a further comment, please do so.
I would like to make one more comment. I would like to make can you hear me well?
Yes.
Yes, okay, perfect. I would like to make a comment to actually Dr. Dozortsev comment. He presented our first case in United States, and he mentioned that we failed. I wouldn't say that we failed, because then our main purpose of this first case was to prove that that progesterone can trigger ovulation, which we did. It was very first case, not IVF, just ovulation induction with very low successful rate. So the odds that we would be successful in achieving pregnancy were very low. Our main purpose was to prove that progesterone can trigger ovulation, which we actually did. So I'm sorry, Dr. Dozortsev, I really wouldn't say that we failed. We were successful in our main purpose, which we proved that the progesterone can trigger ovulation. Simply, we didn't achieve a pregnancy, which was expected because the type of treatment has very low successful rate.
Anyone else who wants to ask a question?
Buenos días.
Good morning. Samuel Escobar, la voz profesional de la enfermería in radio stations. I just want to understand a little bit better the age range at which women could be candidates, irrespective of everything else mentioned here. I want to know about the right age, and also how fast this can be successful, because in understanding that this is a new possibility, some people are desperately looking for a pregnancy. To clarify this for the public, how fast is the effect that you can achieve with this therapy?
Sí, muy buena pregunta.
Very good question. Actually, times do not change for the regular processes. For example, the woman has the right amount of egg cells, and she's a candidate for us to work with her own egg cells. The process of having mature egg cells to fertilize this, it takes 10, 12 to 14 days generally. That is the average, and then the embryos are developed for 5 days. Generally speaking, one of the most widely used techniques is freezing the embryos, because this gives a better control on hormones if women have endometriosis or polycystic ovary syndrome. So sometimes we don't have the same results if we put the embryos in the same cycles. It's a regular practice to freeze the embryos that stops the metabolism. And we can prepare this for the next month to prepare the endometrium for the transfer. What we generally do with this kind of evidence is using the posite agonist one cycle before that causes transient menopause. It's difficult for patients, generates stress and a great deal of anxiousness. It can take the same 3 months that we had with agonists. But the advantage is that this is slightly cheaper, simpler, like more friendly to the body, more similar to what should be happening naturally.
I would like to make a comment if I could. What I would like to add is that this new approach, in my opinion, not only useful or will be useful for patients going through in vitro fertilization or any type of assisted reproduction. I believe that a lot of women experience infertility because of the shortened follicular phase, which is particularly common in women who are older. With age, the duration of the follicular phase shortens. Today, we have a lot of methods, I guess, not many methods, but many companies and many kits which will track ovulation. So they will chase or try to chase the woman's cycle to determine the best time to have intercourse if a woman's trying to become pregnant before IVF at home. Maybe she doesn't have the money or she doesn't want to do IVF. With the approach which we demonstrated with this case report, I believe we can help patients who are trying to become pregnant at home. Instead of chasing ovulation, this protocol can be used to program ovulation, to extend follicular phase, and to give an egg, which is the main source of, I guess, not source, but the main factor determining success of pregnancy, to give this egg a few more days to become competent and help women not to have IVF.
¿Alguna otra duda que tengan?
Sí, Dr. Dimitri can say that this can help women that are looking for pregnancy without assisted reproductive management, but very closely monitored by a specialist. These kind of behaviors can help women to become pregnant without requiring this kind of management. Okay. Another question? Samuel Rivas, sin embargo, publication. What is the likelihood of becoming pregnant in undergoing this treatment? Is it 100% effective or it can fail? There are factors that can help to have higher probabilities, like a woman, if the male is affected, or the reduction in the ovarian reserve, different factors that can give the likelihood that Statistically speaking, according to global clinics, the likelihood of pregnancy is 60 to 65% in the first attempt. A couple undergoes a treatment and 65% of them can become pregnant in the first attempt, irrespective of other factors. Thank you.
¿Alguna otra duda?
Any other questions, comments, doubts?
¿O algún comentario? Bueno, si eso es todo,
Well,
damos por terminada.
We adjourn this part of our talk. We thank you very much for being here.
Agradecemos a los doctores
We thank
que hicieron esto posible.
the doctors who made this possible, Dr. Dimitri, Dr. Alon, Dr. Tralik,
Y la doctora Turner.
and Dr. Turner, who supported us, and Dr. Raymond, sorry.
Agradezco mucho que hayan estado con nosotros.
Thank you very much for being here, and
De sepa que es-
please help us to disseminate this information for people to know that this is possible. Thank you.